So we start with question number 67, and question number 67 is an image-based question in which you see a child with micrognathia and you have 4 options with you. You have to choose the option in which this condition is not found. So the condition that is seen in this image is of micrognathia, if you see clearly. So here you see micrognathia, and this is present in all the 3 conditions except Turner syndrome. So your answer to this question is Turner's syndrome. Okay, so your answer is Turner's syndrome, and there are few things that you need to know about Turner's syndrome, and these are the most common karyotype in Turner's syndrome is XO. The most common presentation of Turner's syndrome in older children is delayed puberty as well as short stature. Delayed puberty and short stature. And at birth, you can identify a child with Turner syndrome if they have lymphedema, if they have widely spaced shield-like chest and widely spaced nipples, and they may also present with left-sided cardiac manifestations or heart problems. And now we come on to the other options. You have Treacher-Collins syndrome and Pierre-Robin syndrome. Both these syndrome are a part of first arch syndrome. Both these, Treacher-Collins as well as Pierre-Robin syndrome. In Treacher-Collins syndrome, you can also find coloboma of the lower eyelid, which is a very consistent finding in Treacher-Collins syndrome. Coloboma of lower eyelid. While in Pierre-Robin syndrome, micrognathia is seen in almost 91.7% of your patients. So you have to remember this. In Pierre-Robin syndrome, you will have micrognathia in 91.7% of your patients. And apart from micrognathia, another important feature is glossoptosis, which is another important feature which is seen in more than 80% of patients of your Pierre-Robin syndrome. Now we come on to the other option that you have, and that is the velocardiofacial syndrome, which is the 4th option, and this is also known as de Gorges syndrome. This is the velocardiofacial syndrome, and it is also known as de Gorges syndrome. It is a deletion syndrome where a small segment of chromosome number 22 is deleted, and as a result you see some abnormal manifestations which you can remember by the mnemonic catch. So you have cardiac manifestations, you have abnormal facies, so you have cardiac abnormalities, you have abnormal facies, you have thymic hypoplasia, you have cleft lip and cleft palate, and you also have hypothyroidism, which may lead to hypocalcemia. So these are the important features of velocardiofacial syndrome, which is also known as catch-22. So now we come on to our next question, question number 68, which talks about pollakiuria. So it is asking you the definition of pollakiuria, and the correct answer to this question is option number C, urine of low specific gravity. So what is pollakiuria? Pollakiuria is a benign condition which is defined as frequent small voids in a previously toilet trained child. And you can get another MCQ in which you may have a confusion with polyuria. And what is polyuria? Polyuria is defined as passage of large volumes of diluted urine which is secondary to an abnormality of concentrating ability, which may be either central due to central diabetes insipidus, or it may be nephrogenic, causing nephrogenic diabetes insipidus. So this is what is about pollakiuria and polyuria. So now we come on to our next question, question number 69. And your question number 69 was again a image-based MCQ. And in this, you have been asked a contraindication for this technique. So in this question, the technique that is used is bag and mask ventilation. Okay. So in question number 69, you are asked about the contraindication to bag and mask ventilation, and the answer to this question is diaphragmatic hernia. Now, diaphragmatic hernia is an absolute contraindication of bag and mask ventilation, and at birth in the delivery room, you can suspect diaphragmatic hernia by the presence of scaphoid abdomen and the bulge of the hemithorax. This is more common on the left side, and hence it is also possible that you may hear the heart sounds more on the right side instead of the left side. Okay, so the answer to this question is congenital diaphragmatic hernia, and it results due to the failure of closure of the pleuroperitoneal membrane. The diaphragmatic hernia results due to failure of closure of pleuroperitoneal membrane, and many other congenital anomalies are also known to occur with diaphragmatic hernia, and non-rotation of gut is almost very consistent in congenital diaphragmatic hernia. So now we come on to our question number 70. So our question number 70 was again an image-based question in which they were asking, this condition is seen in which of the following syndromes? So you see a child with a large head in this question, and the answer to this question is D, all of the above. So now we will talk about large head or macrocephaly. So macrocephaly is defined when the head circumference is more than 2 SD above the mean for a given age and gender. So macrocephaly results when the head circumference is more than 2 SD for a given age and gender. And it can result due to a number of causes. It can result due to enlargement of skull bones. It can also be seen in osteogenesis imperfecta. It may be resulting due to increase in the volume of CSF. It could result due to choroid plexus papilloma. It can also be due to megalencephaly, which is mainly resulting due to the increase in the size of the brain, which causes an increase in the size of the head. And megalencephaly is mainly seen in syndromes like leukodystrophy. It is also seen in neurocutaneous syndromes and lysosomal storage disorders. Apart from macrocephaly, you also need to know what is microcephaly. So macro is large, micro is small. So microcephaly means small head, and it is defined as a head circumference which is 3 SD below the mean of head circumference for that gender and age. So microcephaly is defined as head circumference more than 3 standard deviations below the mean for a given age and gender. Microcephaly can be either primary or it can be secondary. Now primary microcephaly refers to conditions where there is reduced generation of neurons, whereas secondary microcephaly results in patients where the child was growing normally initially, but there was an insult such as some infections or a trauma or a bleed which has resulted in the causing the reduction in the number of dendritic processes, and that is called secondary microcephaly. So now we come on to our next question, which is all of the following except dash may be seen in an infant of diabetic mother. So now we come on to the discussion of a diabetic mother. Question number 71 was asking about infant of diabetic mother. So if diabetes is diagnosed before the pregnancy, it is called pre-gestational diabetes, and if it is diagnosed during pregnancy, it is called gestational diabetes. Now, if the control is poor in the first trimester, it can lead to recurrent abortions and malformations. If the control is poor in the second trimester, it can lead to PIH and preterm labor. And if the control is poor in the third trimester, it can lead to macrosomia and its attendant complications. So what are the complications that can be seen in infant of diabetic mother? You can have macrosomia, you can have asphyxia, you can have hypoglycemia, and you can have congenital anomalies, you can have hypomagnesemia. But annular pancreas is not a complication of an infant of diabetic mother. So the answer in this question is annular pancreas. So now we come on to our next question, and it is talking about neonatal cerebral hemorrhage. So question number 72 is about neonatal cerebral hemorrhage. So your question was, true about neonatal cerebral hemorrhage is that the germinal matrix, a unique vascular bed, regresses completely by 32 weeks of gestation. So the correct answer to this question is option number A. So the germinal matrix is a unique vascular bed that is present in the region of the choroid plexus, and it usually regresses by 32 weeks of gestation. And as we know that the risk of bleeding will be inversely related to the gestational age. So if the child is born at preterm, his risk of having a intracranial hemorrhage is more. So we see that children who are born less than 32 weeks of gestation at a higher risk of developing an intracranial hemorrhage. And bleeding in this part can result in IVH, and IVH is graded from grade 1 to grade 4. And grade 1 and 2 can have normal prognosis. However, grade 3 and grade 4 are more severe, and the neurological prognosis in patients with grade 3 and grade 4 hemorrhages is more guarded. Okay. So now we come on to our next question, that is question number 73, and this is a question about galactosemia. So your options are, the incidence of galactosemia is 1 in 60,000, 1 in 6,000. The enzyme deficiency is glucose phosphorylase. There is inability to metabolize galactose and lactose, and the diagnosis is by WBC enzyme assay. So in this you have to tell the true statement. So true about galactosemia is that there is inability to metabolize galactose and lactose. So we come on to question number 73. So galactosemia results due to deficiency of galactose 1 uridyl phosphate deficiency. You can also remember it by this. So galactose 1 uridyl galactose 1 phosphate uridyl transferase deficiency leads to galactosemia. Its incidence is in 1 is to 60,000, and there is a problem with the metabolism of galactose and lactose, and as a result their metabolites, which are toxic in nature, accumulate and result in various manifestations. Usually the manifestations may be seen as soon as feeding is initiated, and babies may present with recurrent vomiting, loose stool, failure to thrive, hepatosplenomegaly and cataracts. And the diagnosis is by enzyme assay, and the therapy includes omission of galactose and lactose from the diet. But speech defects and other abnormalities, other neurological abnormalities will persist even after galactose and lactose have been omitted from the diet. So now we come on to our next question. Faults about mitochondrial disorders are: option A is may present at any age and by any mode of inheritance. It includes Pearson syndrome. Features may include retinitis pigmentosa, and elevated free-floating blood lactate do not support the diagnosis. So the correct answer to this question is option number D, that elevated free-floating blood lactate do not support the diagnosis. So question number 74 is about mitochondrial disorders. So mitochondrial disorders are mainly mitochondria are mainly involved in energy production pathway of oxidative phosphorylation, and hence they can also be remembered by a mnemonic OXPHOS. Because mitochondria are mainly derived from the mitochondria which come from the ovum, they are maternally inherited. And mitochondrial disorders can occur due to mitochondrial DNA, or they can occur due to nuclear DNA. These mutant mitochondrial DNA, they produce less energy, and symptoms result due to less energy production, especially in organs where energy requirement is very high. It can present at any age, and whenever there is multi-system involvement, a suspicion of mitochondrial disorders is always considered. So there may be patients who present with stroke, they may have hearing loss, they may have vision abnormalities. All the symptoms, when there are multi-system involvement, it will indicate a mitochondrial disorder. So now we come on to question number 75. And question number 75 was again an image-based MCQ, where you see a child and you have been asked which of the following features are not present in a child shown below. So the options that you were given were portwine stain, geographical skull, seizures, and buphthalmos. So when you see this image, you know that this is image of a portwine stain, and this is seen in Sturge-Weber syndrome. This is seen in Sturge-Weber syndrome. And you can remember the common manifestations of Sturge-Weber syndrome by this mnemonic. So in a Sturge-Weber syndrome, you have seizures, you have a portwine stain, which is mainly in the region of the trigeminal nerve. You have unilateral or focal seizures, you have mental retardation, you have glaucoma, and you have other eye problems. So this is how you can remember the clinical features of Sturge-Weber syndrome. Another important MCQ that is usually that you should know, which is associated with Sturge-Weber syndrome, is the CT finding that is seen in Sturge-Weber syndrome, and you find a tram track appearance on a CT in a child with Sturge-Weber syndrome. You see a tram track appearance. So you should know the clinical features as well as the radiological features that are seen with Sturge-Weber syndrome. So now we come on to a last question, which is about stuttering. So the question is, faults about stuttering is: airflow is interrupted, tension is often present, duration of prolongation is equal to less than or equal to 1 second, and eye contact is wavering. So the correct answer to this question is duration of prolongation is less than or equal to 1 second. So what is stuttering? I will just briefly talk about stuttering. In stuttering, it is a defect in the speech which is characterized by hesitation or spasmodic repetition of some syllables. And there is difficulty in pronouncing certain consonants. And this is seen in up to 5% of children between 2 to 5 years of age. This has to be differentiated from developmental dyslexia, and in stuttering, environmental and emotional factors play an important role. So if you keep telling the child that you should say it normally, you should stop, you should not repeat, it will only add on to the problem. So whenever a patient comes to you whose child is stuttering, you should counsel them that this is a benign condition and this will go away on its own. And in the explanations that you have received, you will see the differences that are mentioned between stuttering and dyslexia. So you should keep in mind that making a child conscious of his stutter or pressurizing him to repeat the word again and again in a normal fashion can add to his stress and can worsen the condition rather than helping him.